Okay, well, I'd like to welcome everyone this evening. It is Wednesday, February 18th. This is a special meeting of the hospital board tonight with just one item on the agenda. So I'd like to call the meeting to order. And I know it's not on the agenda, but seeing as how we have so many people in the house, I'd like if you join me in the Pledge of Allegiance. You're willing?
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. All right. I do not have the board here yet to vote on setting the agenda unless I have, do we happen to have Taylor Pittman on Teams? I don't think she's.
Sorry, I'm trying to get rid of this Read AI. Nope, she's not on.
Well, we are unable to set the agenda then, but since it is a special meeting, we cannot add. So we'll move forward. The item of business at hand. And tonight that is policies to review regarding employee compensation and paid time off, benefits, those types of things. And I know that many of you are here to listen and speak, and I would just like to say preemptively that we as a board are not taking any action tonight. This is our first review of these policies. And so I would ask that you give us the time to hear from our administrator regarding his proposed revisions, listen to our discussion as a board, and then we will definitely give you an opportunity to come up and express any concerns you have after the first set of discussions at the end of all 8 policies. Okay, everybody all right with that? Okay, Mr. Patton, would you like to start us off with the compensation philosophy policy?
Well, actually, I have a few sort of preface comments if you don't.
Okay.
But I wanted to first talk about process. So as you described, I wanted to present these documents to the board to get the board's input and feedback. If there are elements of the proposed policies that the board doesn't like, then it doesn't make sense to me that I go out to the employees and try and educate them and then come back and say, the board made changes. So that's the sequence, first the board and then the employees. And so my suggestion would be that after the board is comfortable with the state of the documents, that I hold a series of employee meetings, not just one, but a series of employee meetings where any edits to the documents that were made are presented and discussed. Now, it's clear, and I've said this to the board from the beginning, this is not something I expect anyone to like. I don't like having to propose it, but I think given the options that we have facing us, I hope that folks will see that this is a reasonable approach. And then after we've talked with the employees, we'll want to make sure that HR has a chance to review the documents. And then the final revised documents would come back to the board for action approval, again, allowing for employee or public comment. So the question could be asked, why are we looking at these specific policies? Number one, we want to align our benefits program to more closely match what I would describe as a standard benefit package for healthcare facilities. As our organization has evolved, the benefits package needs to keep up with that evolution. And so there are some of our benefits that clearly are not in line, and that's the ultimate goal. But the real reason for this is that we need to lower our personnel costs. So if you look at the financial performance of the organization over the last couple of years, it has been propped up by millage money, property tax money. And as most people know, the amount of property tax that we receive has been cut drastically. So our ability to cover losses, subsidized losses, is different than it was just a few years ago. As the board knows, at the last board meeting, a revised budget based on actual numbers from the first several months of the hospital's operation were presented, and the projected losses significant. So without going into all the detail of the losses, the one that's most important is the lost cash. And that is $5.5 million for this fiscal year is what is being projected. So to cash, we are projecting that we will lose $5.5 million. Long-term, that's not sustainable. It is just not. And so the plan that we discussed at the last board meeting was for the rest of this fiscal year to try and save $1.5 million, combination of expense reductions and revenue increases. And where that number came from, so if you start at $5.5 million, the benefit of critical access is estimated to be just over $4 million. Now, the revised budget does include several months of critical access benefit, but I was just trying to make a clean big picture. So if we subtract the 4 million from the 5.5, then that leaves the $1.5 million. And my suggestion to the board was that we look for $500,000 in expense reductions and $1 million in revenue. Now we could split it and say 750. I think that we're limited on the amount of expense we can pull out of the organization. That's why I suggested the 2 to 1. As we did the revised budget though, what we saw was that our benefit package amounts to about 32% of our overall compensation costs. That is quite high. In my experience, most hospitals, healthcare organizations our size, would be in the 18 to 22 range. Understanding that the Wyoming retirement program adds costs that most hospitals would have other than those in Wyoming. I would still say that we're 5 to 7% higher on our benefit costs than we should be. So that's why I'm focusing on benefits. So the plan that I laid out to the board was this 1 million in revenue, 500,000 in expense savings. I'm trying to do this in a way that limits the number of layoffs. I mean, ultimately, that's where we may need to go, and I'm trying to avoid that as best I can. I'm also trying to do this in a way that employees won't feel it in their paycheck. And so you'll see in the proposals that I'm going to make to you, this would not change the paychecks that the employees have. It would change the accrued benefits that they receive, but it would not change their paychecks. And so at the end of the day, thinking about it selfishly, how would I feel? I would rather have a little bit less in a benefit that isn't today a cash benefit than to take a cut in pay or to see some of my coworkers let go. So that's part of my strategy in this approach, is trying to do it in a way that limits the impact on paychecks. This isn't the only set of policies that needs to be looked at. Other ones, not to put fear in people's minds, but the way that we're handling shift differentials right now is costing us more than it needs to. We need to define shifts and not allow portions of shifts to be split for different. So an example would be, is a 12 to 8:30 shift a day shift or an evening shift? And by my definition, I go by where are most of the hours. And so in the 12 to 8:30, most of the hours are after 3 o'clock. So for the 3 to 11 shift. So at 12 to 8:30 would be a 3 to 11 shift. And all of those hours should be paid differential. But does an 8 to 5 person get differential for the last 2 hours? So 3 to 5, that's 3 to 11. And I would say no, because the majority of hours are on the day shift. That's not the way that we're doing it now. I believe that we need to standardize that. We're also going to propose to you a change in our shift times. Right now, our shifts change based on midnight. That's very unusual. It's usually 7 a.m. And in our nursing home, we would do it at 6 a.m. That's when they change shift. And so for us to have 6 a.m. in the nursing home, 7 a.m. in the hospital is not a problem, especially with the new HR system that we're putting in. And so some of the changes that I'm proposing will need to be delayed until the new HR system can be programmed. We need to make sure what we're asking the system can be programmed in. And then I'll talk about it briefly, but medical staff approval process for CME and time off. That will relate to the CME PTO policy that I'm going to talk about tonight. So I just wanted to preface the policy presentation with the why. Why are we doing this? So it's a combination of standardizing packages, benefit package, and more importantly, saving money without impacting jobs or employees' pay. So with that, I'll jump into the policies themselves. Okay. So the first one, and this one shouldn't be a bad thing for the employees. It's a compensation philosophy policy. And what it is intended to do is to talk about how we want to provide fair, competitive, and transparent compensation. We need to attract and retain qualified professionals. We need to have internal equity and be reflective of external market conditions. We need to have the ability to recognize individual performance or contribution. It needs to be consistent with the long-term financial stability of the organization. And it also needs to acknowledge the unique issues rural healthcare faces. This is different than a big urban market. So the market competitiveness is the next. So we need to compete within the rural healthcare market, not necessarily urban systems, but many times we still are competing against Salt Lake, Idaho Falls, not to mention Jackson. And for doctors, even nurses, therapists, imaging techs, lab techs, many times it's regional, if not national, that we're competing. And so that's one of the things that the policy takes into consideration. So it talks about we're going to benchmark using reliable industry sources such as the State Hospital Association, Long-Term Care Association, salary surveys, CMS wage indexes, and then National Healthcare Compensation Surveys, MGMA, the American Hospital Association. In general, the policy says that we're going to target the 50th percentile. So we want to be middle unless there's a reason why we need to be above that. And then I already mentioned internal equity. So they need to be guided by job responsibilities, defined job descriptions, education and certification, years of experience, complexities of the role, that sort of thing. And then I talk about how we're going to define, and some of this already exists, it just needs to be modified a little bit. We're going to have all of our pays and pay grades and then steps. So it'll have the following components: base pay, shift differentials, on-call pay, overtime pay, incentive pay, and then incentive bonus pay. I've already talked about rural from one perspective, but I want to talk specifically about the recruitment and retention challenges. So we're saying that we're going to, as appropriate, offer sign-on bonuses, relocation assistance, student loan repayment support, housing assistance or stipends, and where we can, flexible scheduling arrangements. And then talking about annual performance evaluations, hospital financial performance, budgetary constraints. So you'll see that one of the things that I'm going to propose is that we be more consistent in giving what I'll call regular raises to our employees. I know sometimes we say we can't afford to, and I'm going to argue that we can't afford not to. When we don't give regular raises to our employees, we get behind, and then we end up paying for it with catch-up. And we've done a series of catch-up over the last few months. What I'm going to propose is that when an employee gets their evaluation, and I'm going to talk frontline employee, contracted medical staff, some of those would be different, but frontline employee, when they get their annual evaluation, I'm going to suggest should get a step increase, so a 2% raise. Every year, we should look at our pay scales, and as necessary, we should do cost of living adjustments. So the policy is proposing that those be sort of built into standard process. That's not something we've been consistent at in the past. But it does, I want to draw your attention, so it's page 2, number 7, the last sentence. Cost of living adjustments linked to service step increases and merit-related payments are not guaranteed and may be adjusted or suspended based on financial conditions. That wording, I feel, is necessary for unusual circumstances. I would hope that that wording wouldn't be invoked very often, but I think it needs to be there to protect the organization. And then talking about compliance, we're going to be compliant with wage and hour law. We're going to have good documentation supporting our decisions. We're going to avoid anything that could be viewed as discriminatory or inconsistent. The board will maintain oversight of executive compensation and executive pay. That will be set separately from staff compensation. We're going to be transparent about it. We're going to have consistent communication, as I've suggested. After the board has an opportunity to edit these, then I want to go out and do education sessions with the employees. And then we're going to review them at least every 2 years. We're going to update them based on market changes, regulatory changes, organizational strategy, and finally, they will all be approved by the board. So that is compensation philosophy. I'll pause there and see if the board has any questions.
I love the goal to standardize. I think it's really critical, and I think we've had a discussion for years about how to put those standard increases and merit-based needs into place, but because we've been reliant on the mill levy for so long, we just found ourselves in a position where we couldn't make it a standard, but I think it's been one of our goals for a long time, so we're grateful for that being a piece of it.
So then moving on, the plan is that I go through them all and then we offer comment, correct?
Yeah.
Okay, I just,
Any questions?
Not about this one.
Okay.
Thank you. I appreciate you kind of laying that out in terms of just general for everything else. I think that's helpful. Thanks.
so then the next one is compensation program. And so then this one, from my point of view, operationalizes the compensation philosophy. So this talks about how we're going to do that. So in the procedure, you can see in Roman numeral 2 that there will be a master pay range process. I wanted to mention that the numbers there, so 36 pay ranges, 25 steps. As we go through the HR review, those numbers may change. And that's sort of, it doesn't matter what the numbers are. 25 in my experience is high. I'm used to having 20 or 21 steps, not 25. And then if someone were to do the math, if you do a 2% step every time, then is your range 40%? Because as you do the impact of 2% each time, then the range could be perceived. What we're trying to do is to talk about just the overall construction of how the pay grades are defined and the relationship between one and another. So the way this really should work is that step 3 on one scale would be step 1 on the next scale. So that would be the relation between them. So some of this I've already touched on, that we're going to do annual salary surveys, looking at Wyoming and our geographic area. HR will make recommendations. And then the timing of this should be such that numbers will be built into the budget. So this should all be done late winter, early spring, so that then as we do the budget for the next year, the impact of a proposed COLA the impact of the 2% step increases, would be built into the budget. So there wouldn't be, so then the question of, do we need to invoke that, yeah, but phrase? That's the time that would come into play. So let's see. Then there's a section that talks about the process for setting the wages for new hires, that we would have a compensation worksheet. The one thing that I would say there that isn't included in this policy that would be included in others. I think that we need to revisit how we give credit for work outside of our organization. I'm going to argue that a year here is worth more than a year somewhere else. And that, so if I'm a nurse and I was a medical assistant for 10 years, 10 years of MA should not count as 10 years for RN. So as we work through this process, we're going to revise that, and that will help us on maintaining internal equity, because it is just a big problem. If I have 5 years of experience and you have 3, and we just hired you and you're making more than I am, that's just a big problem. And so part of this is designed to prevent that from happening. It has a section that talks about promotions or demotions, and it also talks about temporary. So if I step into a role temporarily with additional responsibility, how my pay would be increased. And then once I step back, that's an area that I really want to make sure from an HR perspective, the mechanics of it work. So that's one reason why I have that one section in red. Those numbers may change as we go through the HR window. And then the last section is talking about status changes. So when an employee goes from full-time or part-time back and forth, their pay doesn't change. PRN, it does change. So we pay a 12% premium to PRN people in lieu of benefits. So when I become PRN, I should get a 12% bump. But then when I step away from PRN into either part-time or full-time, I should lose 12%. So that's what that section is talking about. So that one, as I say, is just operationalizing. I don't think that it should be in the least bit controversial. That is one, though, that will require a lot of review by the HR department just to make sure that the mechanics of it are right. So with that, I will pause and see if there are any questions on the compensation program document.
One question would be, say we do have an employee, they're on a scale, they're working on their education and they get another piece of another person, and then maybe from one group to another. Are years of service going to carry with them, or do they just insert in the new arrangement?
So if I'm a CNA, right, and I go to school and I become an LPN, then we will value their time as a CNA, but not necessarily one-for-one. So they will get credit, if you will. Right. But if it's one-for-one, then we artificially inflate people's pay. Okay.
Yeah, I'm with you.
Yes.
I just want to make sure that there was.
Yes, there
that
will.
it's recognized.
There will be
a way to
map. And again, I would say that internal service is worth more than external service. And in my mind, all things being equal, it's worth 2 steps.
Yeah.
So externally, you would come in and you would be at pay scale 10, step 5. If you're our employee, you would be pay scale 10, step 7.
Because I'd like to see it built in to incentivize our folks to increase.
Yes. And add to that, we help them with their education.
Absolutely.
And part of that, there will be a predetermined formula to help you
Yes.
determine where.
So that it's not done differently for you than it is for you. Right. We want to get this all standardized. Okay.
So is it the intent to do like a cost of living adjustment every year?
If the market requires it.
Okay, so just kind of. Okay, as well as
The step.
the step up.
So, and that's a good distinction. So cost of living wouldn't change the scale I'm on or the step I'm at.
Just everything.
everything just gets inflated by whatever the COLA is.
And it's the base level, right? It's the first step salary, the changes by the COLA, correct? And then
Right,
everything else.
yes. Yes, everything proportionally out.
And then in terms of timing, does this happen at the same time every year for every employee? If it's,
So COLA would. So COLA would happen the same time every year. The step increase would happen at anniversary date. And so for that particular part of this, what I'm going to propose is that part of this be effective July 1. And my thinking is this, that right now we do evaluations all at the end of the year. Everyone gets them all at the same time. We need to make sure that we have a solid evaluation process. So we've got one right now that's 14 pages. That's a little bit too long. So we're going to need time to look at the evaluation process. Because ultimately, so 3 different levels, COLA, step increase, and then merit or incentive. If we don't have a solid performance evaluation, we won't have data to do the third one. So between now and the 1st of July, we're going to have to go back and do all of that work to make sure that then whatever incentive program we want to have in place, we have the evaluation to support it.
that difficult for budgeting if all of those incentive reviews are going on for that?
You make assumptions and you limit. So I'll say a department of 10 people, you can't have 10 MVPs. Right?
Each department gets a bucket.
Yes.
And then.
So that will have to be something that we'll decide. Do we say that a department can have 30% MVPs? And then let's do the math, 60% regular and 10% that don't meet? We'll have to make assumptions like that, but you can't allow everyone to get the incentive, the high, or at least the highest. You can have one that is graded. So maybe you get 0.5% and you get 1% and you get 2%. And then we have a cap what the percentage is. But that's all work that between now and July we'll need to develop. Yep. So then moving on, the next one is a very benign policy. This is just summarizing all of the different paid leave benefits so that in a single document, we can say, these are all the different paid leave benefits that we have. It doesn't get into the specifics of each of them. This is good for recruitment. So if someone wants to know what are your paid leave benefits, we can give them this, and then that covers it. And then if they want additional detail, we go to that. So this one, I don't think there's any controversy to it. So the one that everyone's been waiting for, one of two, is the PTO policy. So the current policy breaks down employees into 3 different categories. 0 to 4 years, accruing 6.15 hours per pay period for a full-time person. 5 to 9 years, 7.69 hours, and 10 plus years, 9.23. I am proposing a 6-step accrual scale. So with shorter windows, so people grow their additional PTO more quickly. And so where we start out at 6.15 right now, I'm proposing it be 6.85. Where the mid is 7.69. On mine, it would be 8.7 to 9.65. And then I'm adding beyond the 10 years, a 13 to 15 and then 15 plus. And my rationale is this. The smallest group of people that we have are the most senior people. And this is and from my point of view, an excellent way to reward those people who have chosen to stay with us a long time. And being smaller numbers, the impact of this isn't nearly as much. So by trying to have a more progressive, smaller increments as we go, that mitigates a lot of the cost of this. Okay. The current policy has a single category. I'm proposing different categories. So the first one would be for non-exempt employees. The second one would be for exempt status of managers and directors. The third one is for VPs and officers. And then the medical staff and the CEO roll into the level 3, but they just start at a higher amount. So, let's see, it's at bottom of page 2. Medical staff members working in clinics and urgent care settings will. And so the way the policy is currently written, have time off for CME activities included in their PTO accrual rates. After conversations with the senior leadership team, I've changed my thinking on that. And so you will see the last document we're going to look at is creation of a new separate medical staff CME PTO pay. And so the idea behind that is that it is not PTO that the medical staff will own. It's a use it or lose it. It doesn't roll over year to year. So it is separate from their regular paid time off, but it is explicitly defined for use for CME activities. So that was a change. And then the current approach with medical staff is that their year-to-year carryover is 80 hours. I'm proposing that that be increased to 100 hours. And I'm also suggesting that when this is implemented, that the current medical staff members will accrue at the 7 to 9 year benefit level. So that would be the equivalent of 38 days per year. Medical staff right now get 6 weeks of vacation, so 30 days of vacation, plus they get holidays. So again, I'm going to talk about it in a minute, but I'm proposing holidays gets rolled into PTO. Then on page 3, we get into the section about limits. So I'm proposing that for employees with less than 5 years, that the cap be 120 hours. That's less than the current caps. And the thinking is that since they haven't been here as long, they haven't had as much time to accrue. So the limit should be less. And part of this is a way to try and control costs, because we acknowledge these because the employees in essence own them on our balance sheet. So we have to accrue for this expense. So I'm trying to reduce that accrual. For the 5 to 10 year people, 160 hours. And then I know that the current policy is saying 160 is going to be the cap. I'm proposing that for the 10 plus people, 200 hours. In my experience, that's a very common limit. And then in future conversations, we're going to need to talk about what we do as far as the people that are over. And I'm planning to bring you a PTO buyout proposal. So that rather than people so if I have 250 hours PTO and I fall under the 200-hour cap, current policy says I'm going to lose 50 hours unless I use it between now and then. I'm going to suggest that we have an option that we could give to people that they can be bought out, but at a discount. And so I'm going to give you numbers that shows 50 cents on the dollar and 75 cents on the dollar actual dollars, so that you can see, so that we can offer that as a way to avoid people just losing hours. And then starting at 6, it's getting into some of the mechanics of how PTO works. But 6 is talking about a different approach related to using PTO for sick time. So right now, if I'm sick for 7 days in a row, all of that comes out of my vacation. The new benefit that I'm proposing is called the extended illness benefit. And so what I'm proposing is that after 3 days of PTO, people can get into EIP, extended illness benefit. And then there are a couple of situations where they can get in right away. So if they're hospitalized, if they have surgery that requires anesthesia, And the reason it has that is that we don't want a dental surgery that's done on an outpatient basis to be EIP eligible. And then also the workman's comp, because workman's comp time off isn't always to the employee's advantage. So allowing EIB to backfill some of the workman's comp time, that's what that's about. It talks about PTO requests being on first come, first served basis, that coverage for holidays for those departments that have to work holidays will be spread evenly. So if I got Christmas off this year, odds are I'm going to get to work Christmas next year. That sort of thing. And then it also says that any requests in excess of 3 consecutive calendar weeks require my approval. That's a long vacation, and we need to make sure that the hospital is properly staffed. And what I'm trying to do is to give the department heads backed up so that if they need to say to an employee, no, you can't have 6 weeks off for vacation, that then I can add some muscle for it. So I already talked about number 8. So 24 hours or 3 days for an 8-hour person. And then they get into EIB. You have to use PTO in quarter-hour increments. And then an important point, differentials are not paid on PTO time. PTO is base salary. And then 11 introduces a new concept. If employees don't give us proper notice when they resign, then we're going to say that we can withhold whatever element of notice they didn't give us from their PTO payout. So if they're required to give 2 weeks notice and they only gave us 1, we're going to withhold 40 hours of PTO so that they actually have given notice. So that's what 11 is saying. So I'll pause there to see if there are questions on PTO. In a sense, you need to hear about EIB and holiday before you can completely put that into context. But if there are questions just on that part of it, happy to answer that.
Hours to accumulate, is that pretty typical that you feel like you have seen in healthcare?
Yes.
That you can accumulate that many hours?
Yes, so this would be representative of at least 3 other hospitals that I've been. And so I started by talking about we're wanting to standardize. I wouldn't be at all surprised that an employee could find another hospital that has a more aggressive PTO policy. But I can also give you examples of hospitals that have a less generous. What I'm trying to do is hit middle of the road.
Okay, you just remind me what our current accumulation is.
So
Remember,
0 to 4 is 6.15. 5 to 9 is 7.69. 10 plus is 9.23. So by comparison, the 6.15, the new policy is suggesting 6.85. The middle of the road, 7.69, I'm suggesting whether you look at 7 to 9 years is 8.7 or 10 to 12 years is 9.65. And then 13 to 15 is 10.63 and 15 plus 11.63. So that's a couple hours more than the current cap. So this wasn't all a take. There are a number of areas where I'm trying to do a balanced approach. There is some give. Okay. So I'm going to move on to the EIB, the extended illness. And I'm sorry.
That's true. So, I like it. I like where there are some gives as well, that for balance. But then my question then would be, do we have the organizational capacity to do all of these things without covering the retirement employees?
Yes.
Okay.
Yeah. So it doesn't significantly change our current staffing models.
Okay.
The hour changes are not that significant. And if you look at the way the progression on seniority, if you look at the seniority of our employees, it would be spread in a way that sort of matches where we're at. the highest increases being on the longer term employees, and they're the fewest that we have. Okay, so I think I've probably talked about most of this with the EIB. So employees accrue EIB, similar to what they do for PTO. But they, just like PTO, you don't accrue PTO on PTO hours. Anything that's non-paid, you don't accrue PTO. Same thing with the EIB. So it's worked hours. Again, it's capped. You can only accrue up to 80 hours. So if I work 85 hours in a pay period, 5 hours of overtime, I don't accrue on 85 hours, I accrue on 80. That's the maximum. And then you can see the accrual rates. So it's accruing 64 hours a year or 8 days. So when this policy is implemented, I'm going to suggest that we seed the employees' accounts with at least 4 days. And I may well end up recommending a full 8 days because that's going to be a non-cash expense. Since the employees won't own it, we won't have to carry this number on a balance sheet. And so with shifting the 8 days of holiday to PTO, doing 8 days of EIB, that would be a 1-for-1. And then I found a typo in number 4. May accumulate at any time is not 20 hours, it's 200 hours. So the idea is that if someone is out for an extended period of time and they don't qualify for short-term disability, by design, that's what this is designed. EIB is supposed to be a bridge between vacation and short-term disability, but not all conditions qualify for disability. And so that's why 200 hours. So basically that gives people 5 weeks that once they accrue that much, that they could be off without touching vacation. So we have 24 hours before you can dip into EIB. When an employee returns from an EIB illness, a release to work may be required. We need to know that the employee is able to fulfill their job duties. So if I'm out with the flu, that's one thing, but if I'm out with something else, a back, and part of my job is lifting, then we need to know whether you're able to lift. So it's not going to be that we require it all the time. It would be specific to the condition. And then 7 talks about coordinating EIB benefits with workman's comp. And again, EIB is used in quarter-hour increments. And just like PTO, differentials aren't paid on EIB hours. And then number 9, employees who resign or are terminated don't receive any EIB. So they don't own it, it's not paid out. Questions on EIB?
Clarifications on, couldn't use that in conjunction with short term, right? Or any other types of leave, like maternity leave or that.
So maternity, and I'll talk about maternity in the context of FMLA.
Yeah.
So this doesn't say that you can't use EIB for FMLA.
So you could.
You could.
Okay.
Yes. So it would be condition specific.
That only was unpaid.
Well, it's 12 weeks, combination paid and unpaid.
Oh, okay. Could use that for compensation.
Mhm. So this one is an entirely new. But I think that it's at modest expense to the employee or to the organization side. So then the big take, this is the one that folks aren't going to like. So under procedure, I'm suggesting that New Year's Eve, the evening and night shifts get holiday pay. It's not recognized as a holiday for accrual, but New Year's Eve, come on, that's a holiday. And so we need to pay overtime for that. So that's a new thing. And then the 8 holidays that we already have, all of those are there. So the folks accrue PTO, departments that are closed on the holidays, they will use PTO to backfill. So right now, there is a non-accrued benefit for holidays. So I don't accrue it, but when I'm off for a holiday, I get paid for it. And then if I work the holiday, I get time and a half. So my understanding is for those people, they're actually getting 2.5. So I'm suggesting that goes away. So they get time and a half for a holiday, that's real standard. So for those that the department is closed, they use PTO to cover it. We're not going to allow people, so if I'm a 5-day, 8-hour person, and there's a holiday on Monday, I'm not going to be allowed to do 4 10s, so I don't have to use PTO. We're saying you accrue PTO for that holiday, we want you to use it. Because otherwise, we're carrying it on the balance sheet, and in effect, we're going to pay you twice for it. Because we're going to pay you full time for the week that you didn't use your holiday, and we still owe you for the holiday. So we're not going to allow schedule modification of that time. Employees will work their normal schedule. And then holiday rate isn't paid on overtime. So if I'm working a holiday and I'm in hours beyond 40, I don't get overtime on overtime. That's pretty standard in the HR world. So that's what number 5 is saying. Number 6, right now, we're at the midnight for shift change. And what's highlighted in yellow is saying that when we do the change with ADP, it's going to go to 7A for hospital. It's going to go to 6 for nursing home. And then the evening and night shifts, that's the shift differential policy I already touched on that we're going to want to update. So the question that has been asked is how much, because from here on, this isn't anything real big for employees, but how much is this going to save us? So if you assume that of the 8 days that are converted to PTO and are replaced with 8 days of EIB, that 6 of the EIB days are used. And this is assuming an average wage of $35 an hour. I think that's a little bit low. And it's assuming 225 employees, which is also low, but I'm factoring in for PRNs that aren't benefited, that sort of thing. I would rather be conservative with the number. But so 35 times 8 times the 2 that we saved, that's $126,000 of savings. If you say that we are going to save 4 of the EIB days, people aren't going to use it, that's $252,000. And if you say that people are going to only use 2 of their EIB days, so we in essence save 6 days, that's $378,000. So I would project our savings somewhere between the 252 and the 378. And that's where, going back to your earlier question of the cost of the incremental changes on the PTO accruals, I believe there's enough factor in there to absorb that change. That conservatively, I can say that we're going to save $250,000 by doing this. And so when you go back to the target that we set of trying to find $500,000 by the end of the fiscal year, we can do a lot of it this way. Now, these are annualized numbers. We've only got 1 holiday left in this fiscal year. So that would be half of 126, which is still a significant savings. And so some of the numbers I think we need to look at annualized, not just this fiscal year. But this is still a substantial savings. And when we look at other ways to save this amount of money, that's 4 or 5 FTEs. So, and it doesn't cost anyone in their paycheck. I get what it feels like losing the 8. I hope people appreciate the replacement of the 8 EIB. I know it's not a 1-for-1, but the goal here is to save money without affecting people's paychecks and without affecting people's jobs. And I believe this does that. So I'll stop. Any questions on holiday pay?
Logistics question, like, what does it look like if an employee doesn't save enough PTO for those holidays that come, because holidays are heavily loaded at the end of the year? How
So-
does that work?
So then it would be without pay.
Without pay.
Right.
Okay.
And the one thing that, I should mention, let's see, where is it? Their employees aren't allowed to request, this is, but actually, they're also, they're not able to request time off in their first 90 days. But if someone is hired, say someone is hired the 1st of May, well, let's say the middle of Memorial Day is coming up, they're not gonna have enough PTO. So in that circumstance, I'm gonna suggest that we go negative. That say they have 5 hours of PTO in their bank, we'll pay them the 8 or the 12 or whatever, and then in the next pay period, they come back positive. That's the one area where I'm gonna recommend that people be able to use if it's in the first 90 days or go negative if they need to, because that's not in their control.
So can they request to just not get paid for that day as opposed to use PTO, or is it only coming to play if they use it all?
So that's a policy we're gonna have to develop. We don't have a without pay policy, or we need to update it. You want to be careful about allowing people to take time off without using PTO. Part of that is to control your schedule, but part of that is to control PTO accruals. So if I'm planning a big vacation at the end of the year, I may not want to use PTO early in the year, but I still want time off. That's going to be a choice the employee is going to have to make. We don't necessarily want to empower the inappropriate use without pay. So that's a separate policy that's already been identified that we need to work. Okay, so then the next one, I don't think it should be controversial at all. I'm just wanting to formalize. This is relocation and temporary housing assistance policy. It gives 3 different methods by which employees can get relocation assistance. And then it has 5 different levels of assistance, primarily based on distance. And so what I did is I went to the U-Haul website and I looked at how much it would cost to rent a U-Haul in these distance areas. And then I added numbers for gas, for meals, that sort of thing. So I believe that these numbers are very appropriate for the distance we're talking about. So it wasn't just I pulled numbers from the air, I actually used them. And I know that some people, especially in the higher categories, will be using a moving company. But this would still define. So if we have someone who was using a moving company, 750 to 1,250 miles, 9,000 would still be good. And that's what option 2C was about. Some employees don't want to front $9,000 and they want us to pay the moving company directly. So it's just allowing for that to happen. Number 4 talks about this is reportable income to IRS. Unless your military has really clamped down on the rules related to recognizing moving expenses as a deduction. For the most part, this is all reportable income. And so we're just saying we're going to report it to be consistent with IRS. Number 5 says that if employees, so level 1 or level 2, so that's $2,500 or $6,000, then they're going to agree to a 2-year service commitment repayment. And we will actually have a promissory note that they have to sign. And part of that will say that if they don't complete the service and they don't agree to repay it, we're going to withhold all of their accrued PTO if we need to, and potentially their last paycheck. All of that will be defined in the promissory note. And then for people that are in level 3, 4, and 5, it's a 3-year commitment that they have to agree to work here for 3 years. And those are fairly standard numbers for that amount of money. And then 6 is talking about the promissory note. And then the next section, temporary housing assistance. Again, this would be reportable as income. And I just wanted to, just so there's no confusion, when we have someone here who is a traveler, part of our responsibility under the contract is to provide housing. We either provide it for them or we pay for it. That is not reportable income in the same way as if we provide housing for someone we've hired and we're saying we're going to give you an apartment for 3 months. So I just want to make sure there's no confusion that people that are temporary, that are travelers, housing is treated differently than permanent employees. That's just the way the IRS does it. If we could do it differently, we would, but we don't make up those rules. So we're saying that temporary housing will typically be 1 to 3 months, and that it won't exceed 6. And that if it does need to be extended, then we may be charging rent. And then the last one, we don't permit animals at any time. If the employee needs to have an animal, then they're gonna have to do housing on their own. Animals just creates, especially if it's something we don't own, it creates all sorts of issues. So questions on the temporary housing? Relocation. Yeah, I don't think that one's controversial, just, yeah, I want to make sure that it's standardized. And then the last one, again, I don't think this should be controversial, but this is the new medical staff PTO for continuing medical education, CME. So at the beginning of each year, we can define year, whether it's contract year for the provider, fiscal year, calendar year. I want to see which is the most practical approach. But then we're going to create a new category of PTO and we'll just dump 40 hours into that. So there's no accrual. And this will be for full-time and for part-time, because a part-time person has to meet the same CME requirements that a full-time person does. And if they're less than part-time, then they wouldn't have CME benefit. But part-time and full-time would get this, the full 40 hours. It's a use it or lose it. No hours are rolled from 1 year to the next. The provider doesn't own the hours. So resign, retire, or otherwise leave, there's no payout of these hours. And then to help Dr. Burnett, I'm going to say that I get to be part of the approval process and that they have to comply with all aspects of the overall CME request and approval. And I already mentioned that's something we're working on. And just to be clear, there are a couple of specific things that will be included in that. So one will be no CME outside the 48 contiguous states. So I understand the argument that if I'm going somewhere, Mexico, Hawaii, Alaska, whatever it might be, and I'm staying within my $5,000 limit, why does it matter? It just doesn't look good. We need to be responsible as far as how we are perceived and spending our money. And this is an area from my experience that can be a hotspot for the community. So I think it's better just to address it up front. If someone were to have some super duper special thing, then they can come and request an exemption to the policy. But in general, this is the guideline. So no CME outside the 48 states, and then no CME for classes that are. So I'm going to Vail and I have 3 hours of CME and it's spread over 6 days. Nope. So I'm going to look at the total number of CME hours and using 8 hours as a day. That's how many days would be approved. So again, this isn't meant in any way to punish or be onerous. It's just meant to be responsible in how we administer the benefit. And so those are topics that Dr. Burnett and I have already talked about, but we'll be developing that policy. We'll get input from the medical staff But that's one that we're going to be working on that complements this new one, the 40 hours of, medical staff, CME, PTO. Sorry, but that's all I've got for today.
That's a lot. Which group bill, I'm assuming it's probably shift a medical staff that this will have the greatest impact on? Is that a correct assumption? Or,
The CME benefit,
no, the paid time off and the shifting PTO around.
so we're going to have to look at individual contracts to see what the wording is on the contracts. Many contracts typically have the phrase that talks about the board having the prerogative to change benefits. So a specific example would be health insurance benefit. You don't want the contract language to tie you into a policy renewal that's not consistent with the contract language. So there are a number of other things. The continuing ed benefit included in current contracts needs to be standardized. They're all over the place. So there are a variety of things that I think we need to open up the contracts and do amendments. And so that would be the process that I would suggest we do as far as contracted members of the medical center.
Okay, and I should have clarified, I didn't mean medical staff specifically into regarding contracted medical providers. I'm talking clinical staff who are shift employees.
So,
Those are
so the ones,
actually.
so the ones that are open on holidays, may be the ones that see this, as the biggest negative. So the clinic people are clinical, but they're not open on holidays. But in essence, everyone is going to have what they perceive to be 8 hours or 8 days of paid time now that's going to be rolled into PTO. So from my point of view, this affects everybody. This isn't just the people that end up having to work the holidays. Yeah. And as I said, I don't like having to do this. I think the policy that we currently have very generous. I wish we could continue to report it. I don't believe we can, especially in our current environment. And I don't see any other way that I can find $250,000 in savings on an annualized basis that won't affect anybody's pay or their job. So that's my motivation.
Understood. I think it's important to, as we have this conversation, to draw back attention to the fact of the percentage, our benefit package is part of our total package too. That's an incredibly high percentage.
And if to that,
National.
so when we did the health insurance renewal, we had an opportunity to go after that more aggressively, to save more money on that by charging the employees more than we did. We chose not to do that. Again, knowing that every dollar that we pass in health insurance premium is $1 less that the employee has to take home pay. So I know some people are going to say that this is just cold, but we really are trying to balance all the different issues. Our health insurance is still a great. I mean, people that I talk to from other can't believe how little our premiums are. But that's just an example of, we had an opportunity, we could have gone, so from instead of 150 to 175 for a family, we easily could have gone to 2.25, 2.5, and still been well, because that's a month. That's not per pay period, that's a month.
Right.
And still been well within market. We chose not to do that. And so I would hope that the employees would see that this isn't, we're not viewing this in isolation. We are trying to look at the broad impact of employee compensation.
I appreciate too, just the work you've done in preparing all of these policies to try to backfill some of those areas and shift shift the balance at the loss around. I think that's important.
And one last comment before you open up for public comment. If folks have other ways that we can achieve these kind of savings, and I know it's easy to, like, cut the CEO's pay, cut the, you can do some of that stuff, but at what point then does it sort of become silly? If people really have legitimate ways that we can save money, I'm all ears. Because we need to find, even if we do this and it's $250,000, we need to find at least another $250,000. And we need to do it sooner than later. I'll be asking for a meeting with the primary care docs to start a conversation with them on the revenue side. So, I'm open to other ideas. For right now, this is the biggest number I can come up with and has the most immediate impact that doesn't affect jobs, doesn't affect pay.
Know the number of hours that a PTO that people can bank. In a typical year, if somebody leaves and we pay that out, like, do you know in a typical year what that costs them? Just out of curiosity.
So they could bank whatever the maximum accrual is if they don't use any.
Right, so that's what I'm saying, if somebody leaves and they have 200 hours banked, and we have to pay that out.
Right.
On a typical year,
Oh, I'm sorry, I don't know what that number is.
I was just curious.
Yeah.
I don't know
It would be
what that costs them.
a bigger number than I would want it to be. Yeah.
I mean, it obviously is dependent on, because that's the only way they get. That costs us money, right? Ultimately.
Right, so in the current environment, that would be the only way that they could get it dollar for dollar. So, I haven't proposed it, but it's something that's been talked about at senior leadership. The idea of having a buyout option. So I've been in organizations where once a year or twice a year. So in the once a year model, it's always the first pay period in November. And in the twice a year model, it's November and April. But you allow employees who have a certain threshold, and it's usually at least 120 hours, that they can cash in dollar for dollar up to 40 hours. And so think about it for 1st of November. That's a nice little check for Christmas. Yeah. I've never seen it done, but I've heard of it being done, that organizations will offer at a discount. So we'll let you use those same numbers. You have to have 120, you can buy 40, about 80 cents on the dollar. I've heard of organizations doing that. Right now, I'm not proposing that because from a cash position, I don't recognize that we'll be able to do that for at least several years. But that is something that down the road could easily be looked at and is a way to help control PTO balances.
Well, I think part of the larger conversation too is the goal of PTO is that people use it. We want to encourage people to use it, not bank it.
Yes.
Right? I mean,
Yes.
that's the goal of PTO. So I think that has to play into this conversation as well.
Yes.
And I understand that we've been through some difficult times where people maybe didn't feel like they could take PTO because of staffing, lacks in the last few months. But I think the goal for us should be that as we start to stabilize and things start to feel more comfortable and that we're all in a better place, that people feel like they can utilize.
Yes, agreed. So as we went through them, I didn't hear of any significant edits based on the current status of the documents. Okay, so then, with your permission, I'm going to plan to schedule a number of employee sessions. And then I'm going to suggest that we not bring these to next week's board meeting. That we allow time for the employees to have lots of input. So that if we need to have 6 meetings, I don't know how many meetings, But I want to make sure that employees have an opportunity to hear this same message, to see the documents, and then to provide feedback. And I also want HR to have a chance to go through them. So I'm going to recommend that I not bring them to you next week.
I'm good with that. I know time is of the essence, but we can call a special meeting and
Yes.
if we need to.
Yes, that's what I was thinking. So if we could aim for middle of March.
Okay.
Middle of March. Because as I say, some of these I'm not recommending actually get implemented until July, because there's additional work to be done. The three would be PTO, EIB, and holiday. Those would be the three. Because those get us the savings. And to your question, then, if we do this middle of March, everyone should be able to have had enough time to accrue PTO for the summer holidays. For Labor Day. So I don't think we would be putting anyone in a crunch. There should be enough time to plan ahead for that.
Thanks, Bill. Any questions from the board? Further questions?
No, I would add one comment. And I kind of coined the phrase when I got asked about some of this stuff. My big concern as a board member, as we've been approaching critical access hospital designation and everything else, don't go broke fast. And now we're across that threshold, and now let's don't go broke slow. And that's really what we're at here. And I know it's uncomfortable and it's talking about all everybody's eggs in the basket. But really, we do need to be very careful at this point in time, so we set off on the right trajectory, so that we don't go broke slow.
Well, with that, I would like to let anyone who's on Teams or in the room provide some public comment, but I recognize there are quite a few people present. So, and not everyone can see who's in the room and on Teams. So all I would ask is that if you'd like to make a comment, please keep it respectful, understand that we're working really hard to try to work through some of these difficult things as best we can from many, many different angles. I appreciate Bill's policies and his work to this end. And I know it's not a fun conversation to have, but it's one we must have now. So that being said, please feel free to come up. Just please state your name in case people on Zoom can't see you who's speaking. And please keep your comments or questions to like a 2-minute max, if you could, just to allow everyone to have an opportunity who would like to tonight. Okay. Just please come up to the mic here.
How's it going today?
Good.
My name's Bridget. I'm in the building department in Sublette County. I work in the marketing office. So I have a question, Bill. You know me. I can't pull it out of my boot, but here we go. What is the freeze on the PTO donation? Is that still going to be available to donate your PTO for somebody who is struggling with their PTO, or is that health issues?
So that's also if I may, that's also a policy that we want to revise. But until we got the cap issue resolved, we didn't want to have someone artificially donating just to, I'd rather give it to you than to lose it. And so that was the intent of the freeze for right now. But no, the intent is once we get through all of this, we'll revise that policy and that option will come back.
I know I have a whole list. I'm just going to ask one more question because I know we're tight.
You'll have other times to ask questions.
I'm going to corner you, by the way. All right. So what is the contract with Core Health, and then also the contract with Health Tech? What are we paying those? Can we renegotiate to save money in the future? Is that something that we can do?
So Core Health is a contract that we've looked at. It was one that I wondered, especially once we got Ryan here, our city director, do we need that long term? What I have been told is that there are services that they provide, at least in the short term, and I'll use short term in 6 to 12 months, that at least in the next 6 to 12 months, those services will be useful, and then we will reevaluate. and if I could use that as a springboard, there are a variety of other contracts that we are looking at as a way to either cancel or renegotiate in an effort to offset additional dollars, additional savings. As it relates to the health tech contract, I don't know whether renegotiation of that would be an option. That would be a call that the board would make. And I don't know whether I'm supposed to say a number, but what I would say is that having seen management fees in other organizations, what we are being charged by health tech is a very competitive number.
I can add to that just for clarification for employees' sake. That contract is with the board and we are required to have that contract in place.
Right.
Because of our USDA loan. It's not something that we can make changes to.
So while you have the loan, that has to be in place, that whole contract.
For a certain contract period. And that at this moment, that's 3 years. So our contract with Health Tech is for 3 years. And it's a non-negotiable at this point.
Okay.
Just for clarity's sake.
Okay, thanks, you guys. Thanks for your time.
Do we have anyone on Zoom would like to speak, Jim?
No one's raised their hand yet.
Well, everyone, my name is Steven Sanders. I work for MSA. My ultimate question is, when you're looking at all this, all the information that goes into the PTO, is this only looking at the hospital staff in terms of the hours that they can use? Because on the EMS side, we're a whole beast. While staff on the medical side of the hospital may use 8 to 12 hours to take a shift off, we take 40-hour chunks. So in the PTO accruing hours that I saw there, I'm just kind of curious how our organization fits into how these numbers are being calculated, if there's being an adjustment for that.
So the use would be the one that would, I think, require specific acknowledgement. The accrual would be pretty standard.
Yep.
Because accrual is based on a standard 8-hour, 5-day week. And so for a nurse that works 3/12s, they accrue based on 72 hours. And so for the EMS team, you accrue up to 80. And then beyond 80 is overtime. So you would, and then being able to use it in 40-hour chunks. I think that's a good idea to acknowledge that that would be an unusual utilization compared to the rest of the organization that should be allowed.
Yeah, because I know like in the current numbers from old ways of accruing PTO to current on the max hours, while hospital staff may have whatever the day count is, if you break it down, their shift chunks that they're going to take off. EMS was substantially less. And granted, I understand we have our rotation of our days, but the way our current schedule, 48, 96 hours, that was a big complaint on that. But
Yeah. So actually, that's an interesting perspective. Let me go back and I'm going to pull a BJ aside. And I want to look at the mechanics of the schedules versus the policy. I want to make sure that it works for everybody. And so I appreciate the comment. I think that's something I hadn't thought of, is the difference in the way that you guys use it in the big chunks. Yeah, happy to look at that.
okay, yeah, that's just something that came to my mind. Is I've noticed in the past 8 years that I've been here, anytime there's a change, it almost always seems to fall on the hospital side, but then the EMS side is looked at, because we are an organization that's completely different from anything else. And being under y'all's umbrella, there's some differences that often get overlooked.
No, that's a great point. And we'll make a concerted effort to make sure that nothing in the policy disadvantages that group of employees.
Okay. And then final question, I hope I have 2 minutes here. The education assistance in terms of helping us with continuing to do and assist with our recertifications. Because most certifications in the health field are 2 years. Depending on your level, can be quite substantial to pay for those on our own. I know there's a current policy that states that you guys can and will help cover up to a certain amount per year or that. But my understanding is that we've lost our education assistance currently, because right now I noticed that we don't have access to what we were using previously to get our CME hours on the EMS side.
So let me go and look at that one. I know that earlier, would be the end of last year, we put programs like new degrees. So if someone wants to pursue their BSA, for example, we had put that on hold just because of the cash implications. But let me go, and actually that policy in general wasn't on my list to look at, but I'll add it to the list, the CME support, because there are groups of employees. So paramedics would be, or EMS would be one. In my experience, rehab folks also have high CME, whether pharmacy, I want to make sure that nurses, lab imaging. Let me go back and look at that policy. Because from my point of view, just share, it needs to be a shared thing. You need to have skin in the game. We need to support you with that. And so let's figure out a way to make that happen.
Think about yours.
You're taking notes for me, Vicki?
Sure. Okay, this takes a lot to get me all the way up here. Ashley, I think you had asked what it would be if somebody was collecting PTO at a 6.15 rate. They earlier wanted to know if they didn't use it at all, how much would that be if they went after a year? That one of your questions.
I was mostly thinking, for the people that are banking, say, 200 hours.
Yeah.
Depending on how many employees we have that get up to that point, like how much is that costing? But just in my experience, like being able to bank 200 seems like a lot to me, but
Right.
in a very different interest rate. That's right. So,
So basically, if the 40-hour employee for 0 to 4 years didn't take any PTO for an entire year, we'd bring them up to the 1.59.9 hours of PTO. So yes, they would be able to bank 160 hours a year if they didn't use a single hour. So, and I didn't say my name or who I am. Sorry, Teresa HR.
So doing the math, if you use my $35 average hourly rate and 200 hours, that's $7,000.
but I didn't know like how often that really happens. How often are we paying her?
So actually, I think that would be an interesting metric for us to track on a quarterly basis and report to the board.
And then one of the other things, Bridget brought up the contracts that we hold, and I know we do have to hold some. What about re-looking at the Apogee contract and see where we are with that thought?
So Apogee, we already have that one in the crosshairs. So the current plan, and based on the survey the last 2 days, I'm going to modify the version. First, I need to talk to the doctors, and then I want to talk to the boards. So we haven't been, the plan was we're going to cancel the contract with that. And then we're going to recruit 4 family medicine docs. And we're going to save $350,000, and we're going to have 2 new FTEs in the clinic. That's the original idea. We're not having a lot of success getting family medicine docs for this summer, fall. So 30-year residents, seems like all of them are locked down. We are getting a lot of interest from second-year residents, folks for next summer. But the question I asked the surveyor, and it goes back to the question we were asking about the ED, can we cover inpatient with APPs? And it looks like the answer is yes. With having a MD provide supervision at least every 2 weeks, and the supervision doesn't appear to be on site. It could be remote. So I've already talked with Lena about this, asking her, I want to make sure that as far as CMS regs and Wyoming rules, but we may well be shifting to assuming medical staff degrees and board degrees to, rather than recruiting 4 family medicine docs, maybe we only recruit 2 and get 2 APPs. And then we can get them pretty sure right away. I have no doubt we'd be, in fact, I reviewed 2 CVs this afternoon.
Fantastic.
So yes, the plan is to move in a different direction than that.
Thank you.
As quickly as possible.
Yes.
Thank you, Lisa. Good points. Anybody on Teams?
So if I could, we'll find a way to get the documents posted so employees can actually go in and look at them. And then I'll work to get sessions set up. And we'll do different times of day so that we can accommodate schedules. With the goal of having employees have an opportunity to really understand this stuff. Both the why and then the specific mechanics of it. And then to be ready to come back to the board middle of March.
Fantastic. And I would encourage all of you to attend, if possible, make yourself available to attend one of those sessions and be able to ask your questions and bring up your concerns. And again, come if you're still not, understanding or set before we take any formal action on this. And I would just like to say that we value the employees so much. We're not looking at this because we want to. We're looking at it because it's necessary. We have been having discussions for a full year and a half about, okay, where do we start? What approach do we start taking? Because we saw things coming. And so this is not something that we want to do or that we're thrilled about. It's just a necessary thing. So I hope you can understand that and rest easy in the fact that we try to take care of it as best we can. Have anything? Okay, so
Madam Chair, I just want to say this has been a lot for the employees to take on tonight without having any previous information. I wouldn't make their silence as a lack of thought or interest with regards to what Bill said about maybe researching other ways that we might be able to come up with equal dollars saved. I would like to encourage the staff to maybe put forth some of those ideas, some thinking outside of the box, so that we can get a more diverse picture of some of the things that we might be able to do. So I wouldn't, like I say, I wouldn't take lack of comment. It's more like, I don't want to say stunned, but not knowing prior to, until recently, what was going on. I think there's going to be needed time to digest what's been said.
yeah, understood. Thanks, Doc. Understood. There was never any intent to take action tonight. This was just a first discussion for us.
So I have a question outside the box, and I'm not sure if we're pursuing. Do we know how much it costs the district for holiday? Considering how many people we pay for holidays. I'm sure we don't pay the entire 265 holidays, but it's just a question that may provoke some thinking.
Question to ask our CFO. And to bring back to the meeting when we have this and take formal action on it. And I would encourage everybody thinking outside the box. We certainly have been for a long time trying to figure out how we have had some of these things off in the past and yet keep a new hospital operating cleanly and well and taking good quality care of our patients. So we're looking at everything we can.
The only other thing is I would think and hope that the employees genuinely understand the motivation behind this in terms of trying to guarantee sustainability of the organization.
Absolutely. Absolutely. I think it's important too that we consider that we are trying to eventually get to a place where we are standardized with most hospitals across the state, at least. And I think that's a goal we have to have, whether we like it or not. I think that's important for us to be in the market with at first. So Anybody else? Any last minute comments? Well, I'd like to thank each of you for attending tonight. And again, please attend the employee education sessions that Bill will hold. Ask questions, bring your concerns, bring your comments. We're not done with this. We will try to hammer through everything that we can to make the impact as minimal as possible. Thank you. And with that, we need to enter into executive session. So I would ask that a motion to just enter into executive session for the purposes of personnel discussion.
So moved, Madam Chair.
Thank you, Ms. Davidson. Okay, motion and a second. All in favor, please say aye. Second. There it is. Thank you. Oh, make it this. I'm sorry. You're good.
Nice to.
Thank you.
Yep. No, we're good though.
Yeah.
You guys, they still-